Doc Talk with Dr. Paul Conley is a production of the Signer Foundation, which is solely responsible for the content. This is Doc Talk with Dr. Paul Conley, brought to you by Plateau Medical Center.
Hello, I'm Dr. Paul Conley, and thank you for tuning in to another episode of Doc Talk. We're going to continue where we left off from one of our previous episodes about breast cancer. Currently, breast cancer is the second leading cause of cancer death in women, with lung cancer being number one. Unfortunately, in the United States, we are projected to have over 40,000 women that will pass away from breast cancer. Women in this country, 1 in 8, will suffer breast cancer in their lifetime. So in a prior episode, we talked about how we screen and how we would look up or work up someone with a breast lump or breast cancer. Today we have Dr. Yancy Short. Dr. Short is going to join us here on the show tonight, and he's going to talk to us a little bit about the workup of a breast lump. So Dr. Short, thanks for tuning in, coming into the show tonight.
Okay, thanks for having me.
So, Dr. Short, we talked about breast cancer, and again, we talked about how many women are affected. And again, I think it's just an amazing statistic that, 1 in 8 women are going to contract breast cancer. So, obviously, there's a lot of women out there that have breast lumps that may not be breast cancer. And I think it's somewhat concerning when a woman, may palpate a breast lump or have a mammogram that may be abnormal. So, with you being a breast surgeon, maybe you can tell us or walk us through a little bit about what is the workup for a woman that presents to your office with the breast lump?
Okay. A lot of times when a woman is sent to me with a breast lump, a lot of times it's picked up on breast exam either by the patient or by a physician. And typically with that we go to like x-ray studies of the breast. We can either do a mammogram or a mammogram with an ultrasound. If a woman has a very dense breast, sometimes we'll even get an MRI of the breast. Once we get the report back on that, the report, if it shows calcifications in the breast, we'll end up doing what's called a stereotactic biopsy that we can talk a little bit about here in a little bit. If it's seen on ultrasound, I can usually do a small needle biopsy of it, which is minimally invasive with minimal scarring and minimal bruising. And if it's just palpable and not seen on any x-ray studies, then we do more of an excisional biopsy of the area.
So in your experience, breast lumps, do you have any statistics or any numbers about, I get women all the time say, listen, I've always had lumpy breasts. I've always felt a lump in my breast if I drink caffeine or whatever, fibrocystic breast disease. So in your experience, how common is a breast lump to be benign versus how often would it be malignant?
Yeah, I don't have any specific numbers, but most of the women I see with lumps, it turns out to be fibrocystic disease. Fibrocystic disease, the best way to think of it is like a lumpy, bumpy breast. It tends to be tender. It's aggravated by hormone cycles as a woman goes through her period, or hormone supplements. Caffeine and nicotine will aggravate it, and it's usually tender and most of the time it's more involved in the upper outer quadrant of the breast. It can be involving one breast more than the other. Fibrocystic disease doesn't really increase the risk for breast cancer, but it can cause palpable lumps and x-ray changes that will need to be biopsied to make sure it's not a cancer, but it doesn't really increase the risk of breast cancer. But most women I see are more fibrocystic.
So, Dr. Short, as a breast surgeon, a specialist in that regard, what would a woman feel or possibly would concern her or concern you? Mm-hmm. You talked about fibrocystic, you talked about maybe hormonal, maybe cyclic or changing with tenderness. What would be something that a woman might be more alarmed about if she's performing, let's say, self-breast examinations that may be something that you would say would be a concerning feature of a breast lump?
Cancer. I feel that women do need to do self-breast exams. Some studies have shown that because they're not medically trained, sometimes they don't necessarily pick them up as readily. But what a woman's going to be looking for is a mass that continually grows. Most of the time it's not tender. You can get dimpling of the skin, which means like a little kind of dent in the skin. If the nipple starts to retract or starts to get nipple discharge, that's more of a concern that you have to worry about being a breast cancer. And a lot of times breast cancer do not have a distinct edge, like a benign cyst or there's some benign masses in a woman's breast called fibroadenomas. They're almost like a rubber ball in the breast, where a cancer, typically you don't have a distinct, because it's kind of growing into the surrounding tissue, you don't have that distinct edge, and it continues to grow. That's the biggest one I'm concerned about, is if a mass is growing.
So now, some breast cancers don't even have lumps. I mean, there's like inflammatory breast cancer. So maybe can you talk a little bit about what a woman would see with that?
Okay. With inflammatory breast cancer, it's basically breast cancer in the skin of the breast. Typically, the skin is red, and you see like the hair follicles leave little pits in the skin. And I think the technical term is called peau d'orange, which is, I think, French for orange peel. It actually takes on the look of an orange peel. The breast is usually fairly hard. It can be fevered. It's a pretty dramatic finding. But that is actually breast cancer in the lymphatics of the skin of the breast.
So we also know, just to touch on it briefly, you know, how many women, you know, annually contract breast cancer, but also men. How many men contract breast cancer, and you know, can they develop breast cancer?
Okay. Yes, they can. This year in 2020, they project about 2,600 men will get breast cancer. It is not as common. The problem with men breast cancer is that most people don't think about it. So by the time they really decide, oh, this is a breast cancer, usually it's a more advanced stage. So a man can have an increased risk. I mean, if your mom had breast cancer or your sister had breast cancer, your risk is higher. You do need to do self-breast exam, and if there's any question, you can have mammograms and ultrasound just like a woman. And it can be biopsied and worked up and treated pretty much just like a female breast cancer. Men can get gynecomastia, which is prominent breast tissue, for a number of reasons, due to medications, low testosterone, if they drink a lot of alcohol, and sometimes it just happens as a man gets older. You can get prominent breast tissue underneath the nipple, and it tends to be very tender, and that is not a cancer and does not turn to cancer. So you can also have benign lumps in the breast, like gynecomastia, but a man can get breast cancer and does need to feel his breasts and to make sure he doesn't feel an abnormal lump, and if so, see his physician.
Yeah, I know in the GI world, you know, some of the medications, you know, that we prescribe for even, you know, ascites or fluid, you know, aldactone, spironolactone. I know that's one of the common things we see with those drugs, and men will complain of tender breasts, but typically breast cancer in a man would be a lump or around the nipple in that area, right?
Yeah, most of the man's breast tissue is immediately underneath the nipple, so typically you're going to feel that same description of a mass that continues to grow. You can have the nipple discharge, the denting of the skin, or the nipple starting to pull in, which are all worrisome signs of a breast cancer.
Okay, so the woman, you know, has been sent to you. She has, you know, a lump, and so she comes to you. At that point, you know, what do you say to her? The mammogram shows something that seems somewhat suspicious. At that point, you know, where do we go from here?
Okay. Well, if the mammogram is showing calcifications, there are benign things that can cause calcifications, like an area of trauma, a blood vessel, fibrocystic disease can cause calcifications, but also early breast cancer and breast cancer can cause calcifications. The problem with calcifications, you cannot feel them. You can't see them with a ultrasound machine, so you have to use x-ray to see it. So that's why we use the stereotactic machine that we have here at Plateau. And basically, it's a way to get at the tissue and make sure you get the calcifications. In that modality, we have the patient lay on a table and put her breast through the hole in the table. We do a computer mammogram and identify the area of calcifications. I numb up the skin and make a very small incision in it and put a needle in there that does core biopsies. We turn that around the clock and remove some samples and x-ray it, make sure the calcium's in it. And then to show where we were and where this was taken from, we put a small clip in there called a localization clip that's smaller than a sesame seed so that we can find that area again. So that's how we typically biopsy abnormalities on mammogram that are calcifications. Solid masses that are seen on ultrasound, I typically will use the ultrasound machine behind me to find the area in question, and I will numb up the skin and make a small nick in the skin and use what's called a true cut needle to biopsy it. Once again, minimal scarring, minimal bruising, minimal pain.
So what about the woman that, you know, has a mammogram that comes back as normal, but they definitely feel a change? Are mammograms 100%? Can mammograms not pick up cancers? what does a woman do who, say, maybe has a quote-unquote normal mammogram, but now feels a lump? What do they do with that?
Basically, mammograms are not foolproof. Nothing in this business is 100%. So a mammogram does not catch every breast cancer. So if you have a normal mammogram, but you have a mass, especially a palpable one that is growing, I'll still a lot of times go ahead and do an excisional biopsy where we numb up the skin and make an incision, actually remove that area to make sure. So typically when you're looking at a lump or evaluation of a breast, you're looking at breast exam, which is a palpation of the breast. You're looking at a mammogram and an ultrasound. If any of those are abnormal, you still go to a biopsy, even if the other ones are normal.
So basically, if there's a question, even with a normal mammogram, you would want to consider the possibility of obtaining tissue or biopsy.
Yes. If there's a mass and there's any question, it needs to be biopsied. Also, if the woman's at a higher risk because she's got a family history or she has a genetic predisposition like a BRCA gene mutation, you tend to be more aggressive with those. So if they have a palpable mass, even if the x-rays are normal, sometimes they still need a biopsy to rule out cancer.
Well, we're going to take a break here. When we come back, we're going to actually continue to have Dr. Short here with us, but we're actually going to bring on Wendy Hara, who is actually our radiology lead, who's actually going to walk us through a little bit about the mammography machine, the ultrasound machine that we have, and also going to walk us through the stereotactic breast biopsy machine. So you guys are not going to want to miss this, so stay tuned and we'll be right back.
Doc Talk with Dr. Paul Conley. We'll be back in a moment. This is Doc Talk with Dr. Paul Conley, brought to you by Plateau Medical Center.
Welcome back to Doc Talk. I'm Dr. Paul Conley, and we're talking about breast cancer. We have Wendy Hara here with us, and Wendy is actually our director of radiology. So, Wendy, when we talk about, mammogram, I know that, women hear, a lot of different things about mammogram, and some of the things they may hear may be the unpleasantries of a mammogram. Maybe you can just walk us through. So, if a woman gets referred for that mammogram, tell me a little bit about what she can expect and exactly, what is involved with a mammogram.
Well, the patient will come in, they'll register in our outpatient department, and it usually just takes a couple minutes out there, and then they'll come back to our mammo department. And Angie is our mammographer. She's very good. She always makes you feel real at ease. And what we do is we'll do 4 pictures, 2 on each breast, and it just uses a minimal amount of radiation. It's not dangerous or anything like that. It's just a minimal amount of radiation. And we take those 4 pictures, and 2 views on each breast. Takes probably 15 minutes to have a mammogram done.
So tell me about these things I hear about, some of maybe the older machines versus maybe the newer technology. I keep hearing things like mammo pad. What exactly does that mean for a woman? Maybe in some comparison with some of the newer technology.
Here at Plateau, we use the mammo pad on every single one of our patients. The mammo pad is actually a foam pad that's placed on the imaging receptor, and what that does is it's called the softer mammogram, and it allows to where the woman doesn't feel as much pain, and it actually holds the breast in place a little bit better, and it lets you get more breast tissue and a better mammogram.
So a woman's had a mammogram. Again, you say, very safe, very minimal radiation exposure, negligible. So she has a breast lump. And we have our ultrasound machine here. And the radiologist, I know sometimes I'll see these reports where they'll say, recommend ultrasound. Maybe you can describe, for the viewers, what exactly is an ultrasound and what can the woman expect when she's going to have an ultrasound of her breast?
Okay. An ultrasound uses sonar waves. There's no radiation involved in that at all. It's a totally safe procedure. That procedure also takes just probably about 15 minutes. We look at the mammogram to see what area we're going to look for, and then we go into the ultrasound room, and it's much like having an ultrasound with a pregnant patient. You have the transducer and you have the gel that they rub on that area, and then what they do is they look for that area with ultrasound. It shows up on the screen. And we can look at those images to see if it's maybe a true cyst that you wouldn't need a biopsy for, or if it's something more solid that we would do a referral for.
So with the ultrasound, is there ever a time, where a woman may need to have an additional ultrasound? Sometimes I'll see things about spot compression views. So maybe you can elaborate a little bit. So for the woman that comes in for the routine mammogram, and there's something there that's not quite normal, what are some of the other things that the radiologist may want for that woman to get some additional views? I know Dr. Short's talked about even MRI. Maybe you can talk a little bit about, being as a radiology lead, what other things, do we have available here?
Okay, well, a lot of times with the mammogram, if we do, it's called a category 0, meaning it's incomplete and we need to call the patient back. What we'll do a lot of times is spot compress, and we actually compress the breast a little bit firmer than what we did on the first. A lot of times normal breast tissue, if it gets in one clump, can look like a mass when in reality it's not. It's just normal breast tissue. So if we press a little harder, a lot of times that will spread out, and that sometimes will clear up if you have to have anything else done. We do spot compression mag views. That'll be looking for calcifications. It kind of allows us to look at the small pieces and make it larger to where we can see it a lot better. So a lot of those callbacks are for spot magnification views, but that's just with calcifications.
So it seems like, we have a lot of modalities now. One, with the mammo pad. So it seems like a woman, should have, a more pleasant experience, having the mammogram, and then the ability to have ultrasound and the other modalities. So I think, again, women need to make sure, if you haven't had a mammogram, just like Dr. Short was talking, and talk to your physician. If you have either family history or just by age alone, if you haven't had a mammogram, please make sure that you talk to your physician and get referred. So then that way you can lead this woman through the process and get the mammogram. We're going to take one final break, and when we do, we're going to come back to Dr. Short. Dr. Short's going to kind of walk us through the biopsy part in which we do the stereotactic breast biopsy. And if we do, unfortunately, have a cancer diagnosis, he's going to talk to us a little bit about some of the different treatment modalities that we have to offer in regards to surgery and how a breast surgeon can basically attack this breast cancer. So you're not going to want to miss this, so please stay tuned, and we're going to be right back.
This is Doc Talk with Dr. Paul Conley, brought to you by Plateau Medical Center.
Doc Talk with Dr. Paul Conley is brought to you by Plateau Medical Center.
This is Doc Talk with Dr. Paul Conley, brought to you by Plateau Medical Center.
Welcome back to Doc Talk. This evening we're talking about breast cancer. Our guest is Dr. Yancy Short, breast surgeon, who's been talking to us a little bit about the workup for a breast lump. So now, Dr. Short, we just had Wendy Hara in here talking about, the different modalities of imaging and the imaging studies that we can obtain. So the woman comes back with an abnormal pathology. It shows breast cancer. So from a breast surgeon's standpoint, maybe you can walk us through a little bit about some of the options that woman may have depending on the type of cancer and how you're able to identify whether there's lymph node involvement, no lymph node involvement. Maybe you can talk to us a little bit about that.
Okay. Well, first of all, when you actually get a tissue diagnosis of breast cancer, you have to decide whether or not surgery is the first line treatment. There are certain breast cancers that do better if they receive chemotherapy first, and that's called neoadjuvant chemotherapy. And if that's the case, they get chemo first, and then I do surgery maybe 6 months later. Sometimes that's very frustrating for a woman because she wants the cancer out now. But studies have shown that there's certain patients that do better if you do the pre-treatment. Like if it's a tumor over 2 centimeters in diameter and they're triple negative, which means they do not have estrogen receptors, progesterone receptors, or a receptor called a HER2 on it, that's called triple negative. Or if they have a HER2 positive tumor that's over 2 centimeters, those women typically get pre-op chemotherapy and then we do the surgery later. There's other factors that sometimes will weigh into getting the chemo first, like if it's a large tumor, it's close to the nipple and the woman wants to save the breast, or if it's a large tumor compared to the size of the breast, or she has a lot of lymph node involvement, sometimes they will benefit from the pre-treatment. So once they've either had the treatment or we go to surgery, then we usually start to talk about the different options they are as far as actually doing the surgery itself.
So maybe we can talk a little bit about, the surgery itself. As far as like a lumpectomy versus a radical mastectomy or mastectomy, and maybe you can talk, because I have patients, when I'm doing a procedure or scope, they say, listen, I can't, have a blood pressure cuff in my left arm because, I had a radical mastectomy or a lymph node dissection. Do we still do things like that, or is that something that we've moved away from? Maybe you can just kind of talk about the way we used to approach breast cancer versus the current treatment strategies.
Years ago, a lot of women presented with very advanced breast cancer, and in that case, they did do what was called a radical mastectomy, and that usually involved removing the breast and the muscles underneath the breast and cleaning out the armpit, and that caused a lot of changes to a woman's body and also to the arm, and they had a lot of problems with what's called lymphedema, which is swelling in the arm. So they've kind of went off that. So as we started doing screening and finding cancers earlier, we went to what was called a modified radical mastectomy, which was there when we started, which was basically removing the breast and cleaning out all the lymph nodes in the armpit, which there's about 30 in an average woman's armpit. They then found that there was probably a lymph node in the armpit that was like the gatekeeper that the cancer would go to first before it would go to the other lymph nodes. And I explain it to my patients as it's like the trunk of a tree. If it's in the trunk of the tree, it can be in the limbs. If it's not, it won't be in the limbs. So then they started finding the sentinel node, which they started off doing a blue dye injection to the breast and injecting it with technetium-99 and using basically a neoprobe, which is a Geiger counter, to find the lymph node in the armpit that the cancer could have went to. It does not mean there's cancer in it. So as we've developed this, we started doing more advanced techniques to where we could do less and less surgery to the breast and still get the same outcomes. I mean, now, if a woman has a positive lymph node, we used to go back and clean it out. If she's going to have radiation to the breast because she saved the breast, we don't have to clean out the armpit anymore. They can do radiation to the armpit and save the woman more surgery. There's a study out now that's even saying that some older women may not even need these lymph nodes sampled in the armpit at all. But when you look at breast cancers, there's two main options you have. One is saving the breast and doing what's called a lumpectomy, which is basically just removing the tumor and normal tissue around it and sampling the lymph nodes in the armpit after I inject them with that substance and using the Geiger counter. That technique to get the same results as removing the breast usually requires some form of radiation to treat the breast tissue I'm leaving behind. A mastectomy removes the entire breast. Most of the time it does not get radiation, and saving the breast almost 100% gets it. But if you do a mastectomy and there's still a lot of lymph node involvement, they may still get radiation. So it doesn't totally eliminate the radiation.
So maybe, as we get ready to wrap the show up, why did you do this? Why are you so, enthusiastic and just so passionate about breast cancer?
Okay. Well, I've had a personal experience with breast cancer. In 2013, I was in my office and my wife called me and said that she had had a mammogram that was basically a class 5, which is pretty much breast cancer. So she actually came home and I actually did her breast biopsy. I did a minimally invasive ultrasound-guided biopsy of the mass. It came out back breast cancer, and about 3 days later I had to tell my wife she had breast cancer. One of the hardest things I've ever had to do. And then after that, she had breast cancer surgery. She chose a mastectomy. She had to have chemotherapy. She had to have radiation. She had to have reconstruction. So I've been through all that. And what I find with breast cancer is it affects the whole family. It affects the kids. It affects the mom and dad. It affects the husband. And everybody goes through it. It's not just not the woman. So I have a personal war vendetta against breast cancer because of what it has done to my family. So,
and I think people unless you're a woman, there's definitely a lot of mental strife. That seems like for many women is part of their identity. Mm-hmm. And in women that I've talked to that even though they're breast cancer survivors, it definitely seems like it plays a role in their psyche.
I do find, and it's not across the board, but I do find that younger women associate with the breast more as part of their of them being a woman, and they tend to want to save the breast more. But you know, going through the surgery, a lot of women, if they have to have chemo, will lose their hair, and some women associate hair with being feminine, and then they also lose their breasts. So it can have a definite impact on the way a woman looks at herself. And so, you know, I think in my case, I tried to make sure she knew that she was still beautiful, even with everything she was going through. And I think the support that you get from family, friends, or if you're religious, your church, and all that will help women through that time period, because it is a dramatic change to their bodies and to their image.
Well, I really appreciate you, Dr. Short, again for coming on the program. And for our viewers, thank you for tuning in to another episode of Doc Talk. Until next time, I'm Dr. Paul Conley. Have a good night.
Doc Talk with Dr. Paul Conley is copyright the Signer Foundation 2020, all rights reserved.